Bismillahirrahmanirrahim. This video is about acne vulgaris and following are the references for this video. Acne vulgaris is a disorder of pilosebaceous unit. It is derived from a Greek letter that is acme. It means primes of life. The vulgaris means common. The acme, the prime of life, because this condition affects commonly the younger people. It is so common in young people that some people consider it as normal. It is defined as a self-limited disorder of sebaceous follicle, typically afflicts adolescents, results in intermittent formation of discrete papular or pustular lesion that may lead to scarring. The age group affected is middle to late teenage, and it may extend to 30s. 85% of the patients belong to this age group. 5% of the people may they present in their 40s and 50s. It affects both male and female, but disease tend to be more severe in males. It is common in all races, but the disease is milder in people of Asian descent. Some drugs may induce or exacerbate acne. These are corticosteroid, adrenocorticotropic hormone, testosterone, gonadotropins, contraceptives, trimethadone, iodides, and bromides. This acne vulgaris is also associated with exposure to cutting oils, chlorinated hydrocarbons, and coal tars. Due to heavy clothing, cosmetic, and tropical climate, there is occlusion of the sebaceous gland that may lead to this condition. There is also some genetic association of this disease, and it is considered multifactorial, while it is also seen in a rare condition that is XYY syndrome. Now coming to the pathogenesis of acne. This picture is showing a pilosebaceous unit. The sebaceous follicle contain a villus hair. When there is a change in the hormonal status, like happens in puberty, there is increased production of the sebum. These sebaceous glands are located on the face, back, chest, and anogenital area. So these are usually affected regions by acne. The sebaceous glands are also located on the eyelids and mucosa, prepuce, and cervix. However, these glands do not have follicles. The sebum is the secretion of the sebaceous gland, and this results from the holocrine uh, cells, and these holocrine cells secrete triglycerides, fatty acid, wax esters, and estrols. In addition to increased production of sebum, there is abnormal cornification of the portion of follicular epithelium, especially in the neck or infundibular region. This leads to dilation of the follicle, uh, the canal of the follicle, and if there is more sebum production, there is desquamation of the squamous cell and accumulation of the keratinous debris. This act provides a rich environment for Propionibacterium acnes proliferation. These are lipase producing microbes that convert lipid within the sebum to pro-inflammatory fatty acids. Combination of these changes produce a distended and plugged follicle that is termed as the comedone. This is the characteristic lesion of the acne, and it also distinguishes it from rosacea. The Propionibacterium acne release chemotactic factor that bring neutrophil to this environment, and by release of hydrolytic enzyme, a pustule is formed. The hydrolytic enzymes and other mediators also attack the follicular wall, and the sebum keratin bacteria escape to the perifollicular region, and this induce inflammation in that area also. So result in perifollicular inflammation in the acne. Acne is divided into inflammatory and non-inflammatory types, and the non-inflammatory type contain the lesion that is termed as comedone. There are two types of the comedones: the closed comedone and open comedones. These are primary non-inflammatory lesions of the acne. The open comedones are a small follicular papule that contain a central black keratin plug. The the black color, is due to oxidation of the melanin, and it is not due to dirt. The closed comedone are the follicular papule without a central visible plug. Because the keratin plug is trapped beneath the epidermal surface, these lesions are potential source for follicular rupture and inflammation. This illustration is showing the events we discussed earlier when there is accumulation or proliferation of the Propionibacterium acne within this comedone. There is chemotaxis of the neutrophil due to chemotactic factors that are low molecular weight substances, and the neutrophils are invited to this environment, and over here the neutrophil, by the release of hydrolytic enzyme, they produce the inflammatory effect, and further inflammation is incited. Finally, the sebum along with keratin, propionibacterium and other debris is released into the adjoining area after the rupture of the wall, and the inflammatory circle starts. This is a comedone with a hair shaft, and this hair shaft is piercing the follicular epithelium and starting inflammation and fibrosis in the surrounding tissue. In this photomicrograph, this is the picture of an open comedone. In this photomicrograph, there is marked acute and chronic inflammation that is extending all the way through the dermis. Many factors are related to acne. These may be intrinsic or extrinsic. Hormone is one of the intrinsic factor. The polycystic ovary syndrome, viralizing tumor, congenital adrenal hyperplasia, increased secretion of cholesterol that happens in Cushing syndrome, and increased growth hormone secretion are associated with acne. Medications such as topical and systemic steroid, oral contraceptive pills, phenytoin, barbiturates, isoniazid, cyclosporine, and lithium are also associated with acne. The extrinsic factors that are related to acne are oil pomades, coal and tar, the chlorinated phenols, DDT, and weed killers. The androgenic hormone effect on morphology of the sebaceous gland by increasing the size of the sebaceous gland, and this result in the increased sebum production in both male and female. Another mechanism is the increased sensitivity of sebaceous gland to androgenic hormone. In some women with acne, there is decreased sex hormone binding globulin with a resultant increase in free testosterone, and this change of hormone balance is mimicked by many combined oral contraceptive pills that result in acne. Oral contraceptive pills that contain more than 50 microgram of ethinyl estradiol can also result in worsening of acne. Estrogen have got opposite effect in prepubertal boys and eunuchs. Infantile acne occur during first few months of the life, and it is commonly due to transplacental stimulation of adrenal gland by maternal hormone, and rarely it is due to congenital adrenal hyperplasia and virilizing tumors. The premenstrual exacerbation of acne is thought to be due to fluid retention, leading to increased hydration and swelling of sebaceous duct. Sweating also worsens the acne, probably by the same mechanism. Stress is another factor associated with acne that has been observed by patient. The pathogenetic mechanism is that the stress induces inflammation in the pilosebaceous unit that is responsible for exacerbation of acne. Within the sebocyte, there is a complete corticotropin releasing hormone system that lead to increased lipid and steroid synthesis and an interaction with the testosterone and growth hormone. Patients believe that their acne is exacerbated by eating certain food such as dairy product, chocolate, nuts, coffee, and fuzzy drinks. The Western diet, including a high level of refined sugar and starch, is also suggested by some studies that this is associated with the uh, acne. There is seasonal variation also. The acne improves with natural light, and in various studies, various clinical trials, the phototherapy with artificial light sources were proven effective. Blue light alone or in combination with red light were effective with the treatment of acne in some proportion of the cases. Some external factors are also associated with the acne vulgaris. These are vegetable or mineral oils, vegetable in case of cooking or mineral oil in case of occupational exposure to engineers. The other acnogenic oils or substances are coal tar, dicophane, DDT, cutting oils, and halogenated hydrocarbons. The women who use comedogenic oil containing cosmetics are also prone to acne vulgaris, while some people use rich hair oil, and they are prone to pomade acne, and this acne is close to the hairline. The acne vulgaris is also associated with some iatrogenic factors. Both topical and systemic steroids can cause increased keratinization of the pilosebaceous duct. Androgen, gonadotropin, and corticotropin can induce acne in adolescents. Oral contraceptives of combined type and anti-epileptic drugs are also associated with acne. The oral contraceptives with high estrogen and low uh, androgens are used to treat acne in women. Use of topical steroids may result in perioral dermatitis, this should be differentiated from acne as this is marked by papule and pustules and not by comedone. Now the clinical manifestations of acne. The duration of the lesion is week to months. It is worse in fall and winter. The main symptom is pain in the lesion. This is especially more in nodulocystic type of the acne. The predilected site for the acne are face, neck, trunk, upper arm, and buttocks. Many skin lesions are present in acne, and they are important to recognize the specific morphologic type of acne. Comedone we have already discussed in detail. These are the non-inflammatory lesion of the non-inflammatory acne, and they are of two types, the open and closed one. The open comedones are also termed as blackheads, while the closed are whiteheads. The papule and pustules are also present in acne. These papule when topped by a pustule, and this lesion is seen in papulopustular acne. Nodule or cystic nodules or cysts are also present, and these are about 1 to 4 centimeter in diameter, and they are characteristic of nodulocystic acne. The soft nodule result from repeated follicular rupture and re-encapsulation with inflammation. As a result, there is abscess formation or cyst formation, and it is also associated with foreign body reaction. So this lesion is soft nodule. Then there is development of sinuses. When there are round isolated single nodule and cyst, they coalesce to linear mounds and sinus tract. The sinus is a draining epithelial line tract. Usually it is seen in nodular acne. Scars are also seen in the acne as a sequelae of the acne. These scars may be atrophic, depressed, often these are pitted, or they may be hypertrophic at times, such as they may show appearance of a keloid. Seborrhea of the face and scalp often present, and sometimes it is severe. So we can summarize the morphologic lesion of acne are comedone, papule, pustule, nodule, cyst, pitted scar, or sinuses. They may present as a small erythematous papule or large tender purulent nodules. This gross picture is showing an inflammatory acne that is associated with erythematous papules and pustules. This illustration is describing the progression of a lesion from microcomedone to the development of nodule. Microcomedone is composed of hyperkeratotic infundibulum. There is presence of cohesive corneocyte with increased sebum production. When there is accumulation of shed corneocyte and dilatation of follicular ostium, the comedone is formed. With further expansion of the follicular unit and proliferation of Propionibacterium acnes, there is perifollicular inflammation also. This results in development of inflammatory papule and pustule that progresses to nodule formation as is seen in D uh, due to rupture of the follicular wall. This is the gross picture of acne vulgaris. There is a mild acne lesion on the back that are showing scattered inflammatory papules and occasional pustules. This is the picture, gross picture is showing comedones. The comedones are keratin plug, and they are formed within the follicular ostium, and they are associated with surrounding erythema, and also associated with pustule formation. Here, the upper arrow is showing a white head or closed comedone. This is due to a small ostia, and the lower arrow is pointing toward an open comedone or blackhead. This black color is due to oxidation of melanin pigment and not due to dirt. And this ostium is larger than that of whitehead. In this gross picture, majority of the lesions are papulo-pustular, but some of the inflammatory papules become nodular, and this represent early stage of nodulocystic acne. Acne severely impacts the social life, as these lesions are widespread and painful, as is seen in this nodulocystic acne. There are both whiteheads and blackheads present on the face of this patient. These open and closed comedone frequently transform into papule and pustule. These lesions coalesce and form large, painful, discomforting nodule and cyst. So this is nodulocystic acne. Many special forms of the acne have been recognized. We are briefly going to look into some of these. Neonatal acne involves nose and cheek in newborn or infant. This may last up to 5 years, and it is related to glandular development. Neonatal acne is transient and self-healing. Acne excoriae occurs usually in younger women. It is associated with extensive excoriation and scarring due to emotional and psychological problems such as obsessive compulsive disorder. The patient picks at the skin that produces disfiguring erosions. Acne mechanica is flares of acne on cheek, chin, forehead because of leaning phase on hand or on forehead. It also occurs due to pressure of football helmet. This gross picture is showing the lesion of acne excoriae, and here the lesions are these disfiguring erosions are produced due to regular picking of the lesion by patient. Another special form of the acne is Acne Conglobata. It is this Conglobata is derived from a Latin verb, and this means to form into a ball or a globe. This form of acne is more common in boys and in tropical climates. There is severe cystic acne with more involvement of the trunk than the face. The nodule coalesce, cyst form, abscesses are formed, and there is ulceration. They occur also on buttocks. The spontaneous remission in this conglobata is rare, and rarely these are seen in XXY genotype or polycystic ovary syndrome. Acne fulminans is a similar lesion of the acne with systemic symptom of malaise, fatigue, fever, generalized arthralgia, leukocytosis, and elevated ESR, and it is thought that this is due to hypersensitivity to Propionibacterium acnes. This affects teenage boys and of acute onset. Pyoderma facial is also similar lesion, and there is erythematous and necrotic lesions also, and this pyoderma facial occur mainly in adult women. Gram-negative folliculitis usually is due to Klebsiella, Proteus, Pseudomonas, and Escherichia coli. These are the gross pictures of Acne Conglobata and Acne fulminans. The lesions are cystic, and these have got coalescing nodules, cysts, and they are also forming a large globular or round cyst, almost similar features grossly, but the acne fulminans is associated with clinical evidence of generalized arthralgia, leukocytosis, elevated ESR, fatigue, and fever. This is the acne conglobata. There is severe nodulocystic acne, and this coalescence of these lesions result in confluent nodule and cysts that are forming linear mounds, and this is due to interconnecting channels. There is pustulation, there is crusting, and also development of a scar. The lesions are very painful. Tropical acne is the term that is given to severe folliculitis. The inflammatory nodules, draining cysts on trunk and buttocks are formed in tropical climates, and there is secondary infection with the Staph aureus. Occupational acne is associated with exposure to tar derivative, cutting oils, chlorinated hydrocarbons, and these are not restricted to predilection sites only, can appear on other covered body sites like arm, leg, and buttocks. Chloracne is due to exposure to chlorinated aromatic hydrocarbon in electrical conductors, insecticides, and herbicides. Sometimes very severe due to industrial accident or intended poisoning, for example, dioxin poisoning. The acnogenic or comedogenic oil or substances are used in some cosmetics that result in acne cosmetica. Pomade oil is used by some Africans on their head, so it results in pomade acne, and this occur along the hairline. Sappho syndrome is a rare condition that is marked by synovitis, acne fulminans, palmoplantar pustulosis, hidradenitis suppurativa, hyperkeratosis, and osteitis. Another rare condition is Papa syndrome. Here, this is an inherited autoinflammatory disorder, and it comprises of sterile pyogenic arthritis, pyoderma gangrenosum, and acne. There are some acne-like conditions which are not acne. They are not characterized by presence of comedone. The steroid acne is developed following systemic or topical glucocorticoids. There is presence of monomorphous folliculitis, and that results in a small erythematous papule or pustule on the chest and back. Drug-induced acne is also monomorphic acne-like eruption due to phenytoin, lithium, isoniazid, high-dose vitamin B complex, epidermal growth factor inhibitors, or halogenated compounds, but there is no comedone seen. Acne estivalis, as the term estivalis means pertaining to summer. This type of the acne-like condition occurs after sun exposure. There is papular eruption but no comedone formation. This occurs usually on forehead, shoulder, arm, neck and chest. Gram-negative folliculitis. In gram-negative folliculitis, there are multiple tiny yellow pustules on the top of the acne vulgaris in long-term antibiotic administration. Presence of comedone is diagnostic feature of acne. Uh, the acne should be differentiated from some other conditions such as Staph aureus folliculitis, pseudofolliculitis barbae, rosacea, and perioral dermatitis that occur on face and on trunk, malassezia folliculitis, hot tub pseudomonas folliculitis, and other acne-like condition, but these are not characterized by presence of comedone. The presence of comedone is essential for the diagnosis of acne. There is no specific laboratory examination is required, but in majority of the cases, the hormone levels are normal. But if there is a suspected endocrine disorder, free testosterone, follicular stimulating hormone, uh, luteinizing hormone, dihydroxyandrosterone, 11 beta or 21 beta hydroxylase are important, and these can be helpful in the diagnosis of hyperandrogenism or polycystic ovarian syndrome or congenital adrenal hyperplasia. If systemic isoretinoin treatment is planned, transaminase, both ALT and AST, triglyceride level and cholesterol level is essential. Now coming to the course of the disease, the acne vulgaris clears spontaneously by the early 20s, or it may persist for the fourth decade or older. The flares of the disease occur during winter or with the onset of menses. The important sequela of the disease that has got the psychological impact on the patient is scar formation, and this scar formation can be avoided by early topical treatment by the isotretinoin. These gross pictures are showing the keloid scars that are formed as a result of acne. This is the gross appearance of the ice pick scars of the acne. Uh, the type of the atrophic scars in acne are box scar, that is marked as A in this picture, ice pick scar B, or rolling scar that is marked by C. For the treatment of acne, the goal of therapy is to remove the plugging of the pilar drainage, reduce sebum production, and to treat bacterial colonization. For this, topical cleansing agent, keratolytic agent, and antibacterial agent are used. For severe cases, topical vitamin A along with systemic antibiotic or synthetic oral retinoids such as isotretinoin are used. Cleansers are used as keratolytics that dissolve the keratin plug of the comedone, and it may result with dryness and scaling of the skin. The topical treatment that are used are benzoyl peroxide that is available in 1 to 10% uh, and it is bacteriostatic and mildly comedolytic. It is available in lotion, cream, gel and washes. So dependent on the skin type, prescription is given. For dry and sensitive skin, prescribe creams, and for oily skin, use solution or gels. And for the combination skin and hair bearing areas, lotions are well tolerated. The benzoyl peroxides are mildly irritant, so it result in mild irritant dermatitis and also result in bleaching of clothing and bedding. Salicylic acids are available in 0.5% and 2% formulation, and they result in desquamation of the follicular epithelium. They are also available in cream and lotion, and they are applied twice daily. Azelaic acid is available in 20% formulation, and it has got anti-keratinizing and antibacterial effect. The cream is used twice daily for 6 months. The topical retinoids are vitamin A derivatives that have got anti-inflammatory and comedolytic effect. Tretinoin, adapalene, and tazarotene are the commonly used topical retinoids. They are available in cream and gel, and they are applied once daily at night because they have got photosensitivity and also associated with skin irritation, erythema, and desquamation. Topical antibiotics have got bactericidal and anti-inflammatory effects. Commonly implicated antibiotics are erythromycin and clindamycin, either alone or in combination with other agents such as zinc or benzoyl peroxide. They are used twice daily. Uh, they have got antibiotic resistance, but this antibiotic resistance is more common when a single antibiotic is used. Phototherapy is another form of treatment, that is the alternative treatment to this uh, acne, and especially this is helpful in those unresponsive cases or in patients who are unable to tolerate conventional treatments. This photodynamic therapy has been shown to be superior to blue or red light treatment for mild to moderate acne. However, there are now handheld blue light devices that have got 2 joule per square centimeter per day and 29 joule per square centimeter per day, and they are associated, the use of this device is associated with 70% reduction in the lesion at 8 weeks after daily treatment to the whole face. Now, the hormone therapy, oral contraceptives are used for the treatment of this acne. The oral contraceptive that increase sex hormone binding globulin. As a result, there is decreased free testosterone level and the high estrogen and lower androgen potential. One drug is Yasmin. Anti-androgen treatment alone can be teratogenic. Cyproterone acetate with ethinyl estradiol is another drug that is available with the name of Dianete, and it also helps diminish mild hirsutism. The mainstay of treatment, antibiotic treatment for acne is oral tetracycline, and it is given to the patient more than 12 years of age because in the patient below this age group, it is associated with dental hypoplasia and staining of the teeth. The treatment of oral antibiotic should be given for about 6 to 12 months. Once daily preparation of limecycline 408 mg, minocycline 100 mg, and doxycycline 40 mg is given and are more convenient to use than twice daily preparation of tetracycline and oxytetracycline. Tetracycline should be avoided in pregnancy, breastfeeding, and children below the age of 12 years. Erythromycin and trimethoprim are also a good alternative. Benefits of the treatment may not be seen for about 2 months of the treatment, but the treatment should continue approximately 6 to 12 months depending on the severity and response of the patient. The use of oral retinoids such as isotretinoin is reserved for resistant disease because it is associated with teratogenesis. There is 90% risk of birth defect. So, uh, before starting the oral retinoid, a pregnancy test should be done, or when the treatment is started, strict contraception should be initiated. The oral retinoids have got tendency to disturb liver enzyme and lipids, so it is also mandatory to do baseline test for the cholesterol, lipid profile, and liver enzyme. These are also associated with mood swings and depression, so should be avoided or given with care with history of mental illness. Initial dose is 20 to 40 gram per day during first 1 to 2 months. Then there is increase in 1 milligram per kg per day to minimize initial cirrhosis. The total target dose is 120 to 150 milligram per kg. The patient may require 2 or 3 courses of the oral retinoids depending on the severity of the disease. For the long-term treatment, 20 milligram per week of isotretinoin is given to the male who have got severe acne. Some warnings are associated with the use of systemic isotretinoin. These are blood lipids transaminase before the therapy, night blindness, decreased tolerance to contact lenses, eczema-like rash as happens in topical glucocorticoid use, dry lips and cheilitis, thinning of the hairs, paronychia, dryness of nasal mucosa and nosebleeds, depression, headache, arthritis and muscular pain, and pancreatitis. This photograph is showing the classic rash that is present on the dorsum of the hand secondary to taking oral isotretinoin, and here this oral isotretinoin use is associated with dry lips. The treatment option for residual lesion are injection with triamcinolone, topical retinoids, chemical dermabrasion, carbon dioxide laser resurfacing, collagen injection, and punch biopsies. To remove the scar from the face and pinch graft applied to the area that is harvested from behind the ears. So, with this background knowledge of the treatment modalities for acne, We have three types of acne, the clinically mild acne, moderate acne, or severe type of acne. For mild acne, we use topical antibiotics such as clindamycin and erythromycin along with benzoyl peroxide gel to 5% or 10%. We can use topical retinoids. There should be gradual increase in concentration point from 0.01 to 0.025% to 0.05, that is available in cream, gel or liquid, and you will choose the formulation according to skin type as we have seen discussed earlier. Surgical options are extraction of comedones, and this is done after pre-treatment with topical retinoids. So for moderate acne, the oral antibiotics are used in addition to the treatment for mild acne. Minocycline is most effective, 50 to 100 milligram per day. Doxycycline 50 to 100 milligram twice daily. That is tapered to 50 milligram per day as acne lessens. Oral isotretinoin can be used uh, and it is used to prevent scarring. Systemic isotretinoin is used in severe form of acne. It is also indicated in cystic or conglobata acne, nodular acne, and acne refractory to treatment. It inhibits sebaceous gland function and keratinization, and it results in almost complete remission in all the cases. It is, as we have seen earlier, it is associated with teratogenesis, and its use along with tetracycline can cause pseudotumor cerebri, that is benign intracranial swelling. Other systemic treatments that are available for severe acne are adjunctive systemic glucocorticoids that are given in acne conglobata, acne fulminans, SAPHO, and Papa syndrome. TNF alpha inhibitors such as infliximab and anakinra are under investigation drugs. The cyst and nodule of the severe acne can be treated by intralesional triamcinolone injections, and 0.05 ml of a 3 to 5 mg per ml solution is used.